Bhattacharjee, consultant medical oncologist at PLS Hospital, Kolkata. October is the month of festivities. October is also the month of breast cancer awareness. And recently, I have been seeing a lot of breast cancer patients who are coming to my clinic with an early stage of the disease. That is an ample testimony to the fact that the breast cancer awareness that has been taken up in the last few years is bearing fruit. So more breast cancer cases are coming to us, and they are coming at an early stage. And as you know, breast cancer caught at an early stage is highly curable. So when a breast cancer patient comes to me, what I advise first of all is to get a true cut biopsy done from the best breast lump. And most of the times the patients ask me that, doctor, we already have a FNAC done, and in the FNAC we have already clinched the diagnosis of breast cancer. So why do you need another biopsy from the breast tissue? Why do you want to stick the needle again? So my point of view is that nowadays the traditional way of treating breast cancer has undergone a sea change. So previously, what we used to do, we just used to diagnose breast cancer. We used to get the lump removed or the breast removed by surgery, and then we used to give chemotherapy and, if required, radiotherapy. But now that is no longer adequate. Now we need to characterize the breast lesion, and we need to get to the depth of the molecular biology of the cancer tissue. In order to get that, we need a true cut biopsy. We need to get a tissue biopsy specimen to do all the molecular tests and the receptor status tests. So what are the receptor status? So a breast cancer, they are no longer a single disease entity called a overall breast cancer. It is actually divided into many smaller subclassifications. One is the hormone receptor positive breast cancer. The second one is the HER2/neu receptor positive breast cancer. And the third one is where none of these receptors are overexpressed, and they are called triple negative breast cancer. As you understand, that the hormone positive breast cancer are the ones which will respond beautifully to hormone therapy, which are much less toxic and which are very good and effective drugs. We have brilliant targeted molecules which are targeted against the HER2/neu receptor. The trastuzumab has revolutionized the treatment of breast cancer. It is an anti-HER2/neu monoclonal antibody. It targets the breast tumors which overexpress the HER2/neu receptor, and it goes there and kills the tumor itself. And apart from that, there are situations where none of these receptors are positive. They are called triple negative breast cancer. Just a few years back, we could not provide any good treatment to triple negative breast cancer apart from chemotherapy. But now what we can do is that we can further subclassify this triple negative group of breast cancers into various molecular subtypes. For example, the basal-like, mesenchymal type, the mesenchymal stem cell-like, luminal androgen receptor-like. These are the various molecular subclassifications into which we divide the triple negative breast cancer, and we can still allow some targeted therapy into this group of patients. Apart from that, there is a novel concept of the BRCA gene mutation, which may cause some kind of hereditary or familial breast cancers. So if we can detect the BRCA gene type in those patients, in triple negative breast cancer patients, then we can give them a brilliant therapy in the form of PARP inhibitors. These are the specific targeted therapy which actually prevent the DNA repair mechanism in the tumor cell, thereby killing the tumor cell themselves. Along with that, we can go for a PD-L1 status in the triple negative breast cancer group, where we get to know whether this group of tumor will respond well to immunotherapy or not. As you know, immunotherapy is a new therapy which has come up in the last few years, and that actually strengthens the patient's own immune system and thereby the immune system attacks the patient's tumor. So these are the various aspects which has come up in the recent years. There are other concepts as well. There are newly developed drugs which are called antibody and drug conjugates. So you have the antibodies which would, like trastuzumab, which will target a specific receptor like HER2 in breast cancer and thereby killing the tumor. And you have chemotherapy, which will again, when inserted into the tumor, it kills the tumor. So why don't we join the two and get an additive effect? So that's the concept of antibody drug conjugate. So there are a few drugs which are coming up, are in the pipeline. The drug trastuzumab emtansine is already available in the market and has produced brilliant results. And there are some other drugs which are being developed in the West, which will be coming in the in next few years, like trastuzumab, fam trastuzumab deruxtecan, which is going to come up in the next few years, and it has produced brilliant results in the HER2 positive breast cancer space. So the future is really exciting. So many new drugs are coming up, but the most important aspect is the one that I want to again go back to, is the molecular and receptor characterization of the breast cancer. That is our starting point. We need to classify the breast cancer, and thereby we can give proper effective treatment to the breast cancer patients to provide them a long life filled with quality. Thank you.